All right, well, welcome to today's panel, Medicare Advantage, Supplemental Benefits, the Business of Caregiver Support. I'm excited to hear from our experts who will help us unpack this emerging topic. I'm Dan Polsky, Director of the Hopkins Business of Health Initiative. HBHI, as we like to say, is a Hopkins-wide initiative bringing together scholars from across the university, working together for an accessible and trustworthy healthcare system for the nation that delivers value and affordability to society through a focus on the role of business and incentives. And we're fortunate enough today to be collaborating with the Hopkins Economics of Alzheimer's Disease and Services Center on an issue that overlaps the mission of that center and the center here at HBHI. And today's conversation on the business of health, we bring together our experts on this particular topic of the day, and Professors Kate Miller and Jennifer Wolf are leading experts here at Johns Hopkins on today's topics. They're both faculty in the Department of Health Policy and Management in the Bloomberg School of Public Health, and they are our amazing moderators for today's event. So I will turn it over to them.
Wonderful. Thank you so much, Dan. Good afternoon, everyone, and welcome. Thank you all so much for coming to today's webinar about Medicare Advantage plans and vendors and how they are approaching family caregiver supports. As Dan mentioned, my name is Catherine Miller, and my co-moderator, Dr. Wolf, on the line here. We're both very excited for this conversation today. And so before we begin, just a few quick housekeeping notes. As you have seen, the webinar today is being recorded. We will make the recording available afterwards. If you could please use the Q&A function at any time to submit your questions. We'll save some time towards the end to try and address as many as we can. This is designed to be a little bit more of a conversation, so panelists will not be using slides, so we do really encourage you to engage through the Q&A. Our discussion today will cover four main areas. First, the business model for caregiving vendors and Medicare Advantage. Second, the payer implementation of caregiver supports. Third, how well these supports align with caregiver and care recipient needs. And finally, what's working, what's not, and ideas for improvement. We are especially fortunate to have a panel that brings together vendor, payer, and caregiver perspectives. And so with that, I will turn it over to my colleague, Dr. Wolf, who will introduce our incredible panelists and provide some level-setting context to kick off today's discussion.
Thanks, Kate. I'm delighted to be here today and to have the opportunity to introduce our panelists. First, we have Dr. Madhavi Vemireddy, who's CEO from Cleo, which is a service caring for unpaid caregivers and is representing the vendor perspective. Next, we'll hear from Dr. Emily Jaffe, Vice President and Executive Medical Director, Enterprise Palliative Care Strategy and Implementation at Highmark Health, who's joining us from the payer perspective. And then finally, we have Marisa Scala-Foley, who brings the broader societal perspective as Director of the Aging and Disability Business Institute at US Aging. So I'll invite each of you to briefly introduce yourselves, your role, and one key insight or challenge you want to highlight about caregiving supports in Medicare Advantage. We'll start with Dr. Vemireddy, then go to Dr. Jaffe, and then finish with Ms. Scala-Foley.
Great. Thank you, Jennifer. Pleasure to be here with all of you. My name is Madhavi Vemireddy. I'm the CEO of Cleo, physician by training in internal medicine, and I've been in population health and advanced clinical analytics for the past 25 years. I'm also an active caregiver for my own children. I have a 14-year-old and a 10-year-old, and my eldest is on the autism spectrum. And part of the sandwich generation, taking care of my parents who need support with some of their day-to-day activities. And so one of the key gaps I wanted to fill was really taking a population health approach to supporting family caregivers, given the strain that they are facing, especially for those in that sandwich generation. So Cleo's focus is on how do we support families across all stages of life, including those that are taking care of an adult loved one. And I would say the insight that I have from our experience of taking care of families is that, we have essentially a patient-focused care model today, right? And the caregiver is largely invisible, even though they are the largest providers of unpaid care and are taking on more and more the daily responsibilities of caring for an adult loved one, especially those that are 65 plus. And so we really have to move towards a family-centered care model so that we're looking at the needs of the caregiver as well as the care recipient.
Thank you. Dr. Jaffe?
Yes, hi, I'm Emily Jaffe. I am a geriatrician and a palliative care doctor by training, and have spent my career in alternative care models where we look to keep frail older adults in the least restrictive environment, because we tend as a society to sort of default to the highest level of care. And one of the key components of that of keeping people in the community is having the right care at the right place at the right time. So Dr. Vemireddy and I think we're very much aligned on this view. Highmark Health, so that you know, is a organization that owns a provider network in Western Pennsylvania, as well as Highmark Inc., which is a Blue Cross Blue Shield product that is active in Pennsylvania, New York, West Virginia, and Delaware. My role is to think about how do we take care of our members living the last part of our lives, or our members living with a high disease burden, whether that's through benefits, medical policy, incentive programs, clinical programs. I'm also the executive medical director for our community-based palliative care program, which cares for about 6,000 of our members. So I think the biggest sort of challenge or insight that we have is that caregiver is a big basket, right? And what do we mean when we say caregiver? And even sometimes we have caregivers who don't know they're caregivers, or don't identify themselves that way. So at the health plan, when we think about this, we think about, is this a paid caregiver? Is this a family caregiver? And then another component of it, or another complexity, is that caregiver our member? And are they caring for another member, or are they caring for someone who's not a member? And all of those sort of combinations adds a layer of complexity when we go to tackle this problem.
Thank you. Marisa?
All right, great. Thank you so much. It's a pleasure to be here with you all. As Jennifer mentioned, my name is Marisa Scala-Foley. I direct something called the Aging and Disability Business Institute at US Aging. And I'll start with sort of our top level organization and then kind of move into what we do at the Business Institute. So US Aging is the national membership association for the more than 600 area agencies on aging that exist around the country. We also advocate for what are called Title VI, which refers to the Older Americans Act, Native American aging populations. And, we support our members in their mission, which is to keep older adults living with independence and dignity in their homes and communities. If you're not aware of what area agencies on aging are, they were formally established under the Older Americans Act as the on-the-ground organizations that are charged with helping older adults and caregivers, and in most cases also younger adults with disabilities, to live with independence and dignity in their homes and communities. And for more than 50 years, they have served as the local leaders on aging by planning, developing, funding, and implementing local systems of coordinated aging and other home and community-based services for people within their what are called their planning and service areas. And AAA's planning and service area, it can vary from state to state depending on how the state has sort of carved up those planning and service areas. In some situations, it may be a city, such as in Boston or New York or Los Angeles. or Chicago. In other states, a AAA's planning and service area may be a county, and in some it may be a group of counties. It really just depends on the state. And I would add, if you're interested in finding your area agency on aging, the area agency on aging that serves your community, you can look at the Elder Care Locator, which can be found at eldercarelocator.acl.gov. So about the Business Institute, we are focused on helping area agencies on aging, other aging and disability community-based organizations, and networks of those organizations, which are often led by what are called community care hubs, to build and strengthen their partnerships with the healthcare system, and primarily to focus on how community-based organizations can contract with health systems, health plans, accountable care organizations, and other kinds of healthcare providers and payers to in order to get people, as Emily pointed out, the right care in the right place at the right time, and largely within their homes and communities. So we do that through a number of different means. We do training and technical assistance. We have a host of resources available on our website, which is agingandisabilitybusinessinstitute.org. We do information gathering through periodic surveys of community-based organizations to gauge the extent to which they contract with healthcare providers and payers. We provide consulting services, thought leadership, and we are also the home of the Center of Excellence to Align Health and Social Care, which is funded by the Administration for Community Living. And we fund and support community care hubs around the country that lead networks of community-based organizations in their healthcare contracting efforts. And I'll leave you with this, our insight in terms of how caregiver supports are being implemented within Medicare Advantage plans and how that relates to the community-based organizations whom we serve within the Aging and Disability Business Institute is that, and I'm going to share this data when we get into some of our questions later on, is that we have learned that this contracting between health plans and community-based organizations has grown over time, particularly within the past few years, as the supplemental benefits under Medicare Advantage plans have grown and have become more flexible. So we're seeing more interest from health plans in terms of working with CBOs in communities who have those trusted relationships with older adults and caregivers to be able to support this work.
Wow, well, I was excited about this conversation before, and now I'm even more excited. So before we move forward with our moderated discussion, though, I just want to take a moment and set the stage to orient ourselves to the context. To say that we know that more than half of Medicare beneficiaries are now enrolled in Medicare Advantage health plans, which are offered by private companies like Highmark, to bundle together Medicare covered services, and that these plans, as the panelists have mentioned, offer extra supplemental benefits that can include vision, dental, hearing, or transportation services, as well as caregiver supports, but that these supplemental benefits can vary from plan to plan. And as the panelists have noted, family caregivers have a really key role in meeting the needs of older adults with complex illness and disability. We know that supporting family caregivers and providing education can advance value-based care and address some of the challenges that can occur related to assuming this role. And we know that some Medicare Advantage plans are including caregiver supports as part of the supplemental program. And so today we're going to be able to explore this topic, hearing from our amazing expert panelists. So I'm going to turn it over now to Dr. Miller to moderate the next step of the discussion. And then I'll just note that we do have Q&A functions. If as you're hearing the panelists speak, there are questions that arise.
Wonderful. Thank you so much. So to kick us off, now that we have that context about the prevalence of MA and the important role that family caregivers play, I was wondering if each of our panelists could please speak briefly to broadly what the business model for caregiver supports looks like. Dr. Vemireddy, would you like to?
Yeah, absolutely. I think as we think about the business model for caregiver support, it's really important, especially with Medicare Advantage, to align on where are there opportunities to improve overall health outcomes for the MA member, right? And as we think about, and Dr. Jaffe also mentioned that MA member could also be a caregiver, right? So for us, it really starts with understanding the needs of the MA member, doing a holistic risk assessment around not only their physical health, emotional health, but also social health and their healthcare experience. And also understanding, do they have a caregiver? Sometimes what we hear from MA members is, yes, they have family members that are helping, but they don't want to be a burden on them. So they're not going to them necessarily early on to ask for that help, which is part of the problem because they wait until their health has deteriorated to then ask for help because they don't want to be that burden. And if they are also in a role of caregiving for a loved one, we know that's going to have an impact on their own health, right? It's going to impact their own self-care, emotional wellness strain, potentially, early signs of depression, anxiety from that as a result of that strain and caregiving responsibilities. So it's having a holistic view on what's happening with that MA member and, who are the family members supporting them. But then focusing on how do we not only support that MA member and their caregivers, but providing that support so that we are helping with more comprehensive care coordination. We're identifying gaps in care, right? We're helping them close those gaps that may align with STARS measures, or helping them manage their conditions better so they're not, they're avoiding unnecessary emergency, department visits. So it's taking that holistic view to see where can we improve the health outcomes of the MA member. And that's where we drive that business alignment, right, to the Medicare Advantage plan.
Thank you.
I can add on to that. When we say what is the business model, there isn't one yet, right? There isn't a sort of standardized business model around how do we tackle the definition and need, outcomes, reimbursement for caregivers. So from a payer perspective, I can say we're working on that, right? And we've been encouraged with the flexibility in supplemental benefits to do so. So, I started saying, who is the caregiver? So we could start by saying, I totally agree, it's about the health and the experience of the member, right? So is it a preventative wellness service that we're providing to a caregiver? So are we looking to prevent hypertension? Are we looking to prevent depression? Are we looking to prevent weight gain? Even burnout, right? So if our members on the recipient end of this, what are we looking to accomplish? So I think that's a very important thing to ask when you talk about what the business model is, which sounds so simplistic, but you really can get tied up in the web of this and have to sort through it. The other thing is that, health plans are not directly reimbursed from the government for paying for caregiving. So when they do things like, pay for glasses, pay for hearing aids, pay for caregiver support, transportation, food, everything is nice to have. And if we gave that to everyone, then we would have nothing to give to anyone. So it's really about figuring out what's the right benefit for the right member at the right time. And so the other thing is that caregivers are a limited resource. Never mind, take the financial out of it, right? So, yeah, we want to partner with our CBOs. We probably don't have enough CBOs and enough caregivers right now if we identified everybody and got everybody what they needed. So we have to be thinking about where do we put this precious resource? And so a lot of times when we think about supplemental benefits, we're thinking about what is the clinical situation that we're trying to address. So are we trying to think about treating someone at home or in the community for an acute illness? So bringing a paid caregiver in for a short term. We have some supplemental benefits designed around hospital transition. So if someone wants to go home, maybe having some non-skilled caregiver in the home could help somebody manage in the house for a few weeks as they get their strength back. Does someone have a progressive illness? And so are they eventually not going to be able to remain in their home? And so what does that situation look like? And then finally, of course, end of life and hospice, about having caregivers in the home. So there are multiple business plans. And I think that what you have to think about is, where is the need the greatest? What's most important to the member, right? So, you can sit and build all the business cases that you want, but you really have to start with, what do the members need? And then what's going to have an effect on their quality of life and their outcomes.
Wonderful. Thank you very much.
All right, so I'm happy to kind of pick up from there and present the CBO side of things. So as I mentioned before, one of the things that we do at the Aging and Disability Business Institute is we conduct periodic surveys to gauge the extent to which community-based organizations are in fact contracting with healthcare organizations. So just a little bit of background, we start with our punchline in all of this is really sort of, and we start with that punchline of how are we doing when it comes to CBO healthcare contracting? And then we'll drill down a little bit into sort of caregiver support and the growth that we've seen, as I mentioned earlier. So we have done 5 waves of this survey now since the Business Institute's inception. Our first was in 2017, and our last one was in 2023. Late 2023, we'll be fielding another one in early 2026. So when we started the survey, about 38% of responding community-based organizations indicated that they had one or more contracts with healthcare providers or payers. And by 2023, that was up to 47% of CBOs who were responding to our survey. And one of my favorite statistics out of our 2023 survey is that 86% of CBOs with contracts, not only have they gotten the contract, but they have had a contract renewed by a partner. So not only are CBOs and healthcare organizations contracting, but they are also keeping those contracts. So in terms of their most common healthcare partners, as you might expect, Medicaid managed care plans are at the top of the list, followed by state Medicaid agencies in states in which they are there isn't managed long-term services and supports. Hospitals and health systems, VA medical centers, and commercial plans round out that top 5. But since the inception of the supplemental benefits, we have seen growth when it comes to contracting between CBOs and Medicare Advantage plans. And up from, it was about 5% of contracting CBOs in 2017 indicated that they had contracts with Medicare Advantage plans. And by 2023, that was up to 21% of contracting CBOs. So statistically significant growth. In terms of the most common services provided under contract, care coordination is really at the top of the list, followed by assessments, person-centered planning, and home care. But as I mentioned before, we have seen pretty significant growth when it comes to contracting between CBOs and healthcare organizations and the role of caregiver support, training, or engagement in those contracts. So when we started doing the survey in 2017, about 18% of responding CBOs indicated that they were providing caregiver support under at least one of their contracts. By 2023, that was up to 31% of responding community-based organizations indicated that this was at least one of the services provided under their one of their contracts with healthcare providers and payers. And I will leave you with this, and that is that recent data, you've already heard from Dr. Jaffe from their plan's perspective. Recently, ATI Advisory, which is a consulting firm here in the DC area that does a lot of work with health plans and health systems, and they've done a lot of analysis work when it comes to the Medicare Advantage supplemental benefits. And recently they released some data on the 2026 supplemental benefits offerings from Medicare Advantage plans. And looking ahead to 2026, the proportion of MA plans that were offering supports for caregivers as part of the supplemental benefits will nearly double since last year, from about 6% of Medicare Advantage plans to 11%. And the reasons why, in terms of what pain points are for plans is, one, reducing burden on caregivers so that they can help to keep older adults, other Medicare beneficiaries in the home for as long as possible. Second, delaying avoidable long-term nursing home care wherever possible. And then finally, of course, reducing hospital emergency department and post-acute care utilization.
Thank you so much. It's such wonderful information, and I'm loving all the statistics. I want to follow up on a thread that you all have started to bring up, and this idea of potentially misaligned incentives. And we do hear that one of the big challenges in this space, right, of course, is that vendors need sufficient volume in order to enter a market. And then, of course, health plans want the evidence before committing resources. And so we have this tension that's occurring. And so my first question is for Dr. Vemireddy. And I'm wondering, can you talk a little bit from your perspective briefly what strategies might exist? How could we potentially bridge this gap?
Yes, absolutely. Thanks for the question, Kate. I agree. That's a lot of what we hear is, there's different aspects of caregiving support that is being provided, right? Sometimes it's just focused on respite care. It could be more comprehensive care coordination support. The other big challenge is, how do you identify the caregiver, right? Because that's not in a structured data format that you can ingest. And, so you have to go find the caregivers, which means we have to start with the MA members. And so, for us, to demonstrate the value, typically, one of our ways we help bridge that gap is say, let's come in as a quality improvement program where we are focused on the MA member, understanding what their needs are, understanding where they have gaps in care, and through that process, understanding, are they a caregiver? Because that could be a barrier to them addressing their own care needs, right? And so we have to support them as they are caregiving for their partner or spouse, or maybe an adult child. And then understanding who is caregiving for them. Because sometimes it could be a local caregiver, a family member that's taking care of them, but it could be someone that is across the country that is caregiving at a distance for them, right? And us then having the permission to reach out to that caregiver, to engage that caregiver as well, because in the support we're providing, we're seeing significant burnout risk with the caregiver, right? Especially if they're in that sandwich generation. Almost 50% of our sandwich generation caregivers are at high risk of burnout. And when we look at the high risk of burnout cohort, 3/4 of them are scoring positive on a PHQ-9, 60% impact to their own self-care. So if that caregiver is already at the stage of burnout and their own health, physical health, emotional health has been impacted, they are not going to have the ability to take care of their adult loved one, right, to the extent that they need to, right? And so and then they're being forced to make decisions about, looking at nursing homes or assisted living facilities because they can't keep them in the home. So for us, it's, we help bridge that gap by understanding the needs of the care recipient, which is that MA member, and then the needs of the caregiver. How are we supporting both of them? Again, to focus in on driving that improved, overall family health. And so, similar to, what Marisa was talking about is, our goal is comprehensive care coordination, because that is a big gap, right? Family caregivers don't know even where to start to help connect the dots and bring in the right community resources, as well as have an understanding of like, what are all the supplemental benefits that are available to that member? Because sometimes they are paying out of pocket for transportation or out of pocket for meal delivery, not realizing the fact that that is an available benefit, right? So that benefit navigation is very key, support that we provide, as well as that care coordination. And then it's coaching specific to that care journey they're in, so that the caregiver understands what's coming next. What are those early warning signs? When do they need to be proactively seeing their physician? And so having that comprehensive family-centered care approach, I think is really key to help, bridge that gap.
Wonderful. Thank you so much. And Dr. Jaffe, I'm wondering, can you speak a little bit, and you started to touch on this, can you speak a little bit about what a health plan can do to try to bridge this gap, and when it comes to providing caregiver supports, what can plans actually get reimbursed for, if any aspect of it?
A straight Medicare Advantage plan is going to do this through supplemental benefits. They're not going to get direct reimbursement for it, but that doesn't mean they're not going to do it. I mean, Marisa sort of outlined for us that, plans are jumping in on this and recognizing it. And you had asked about, we want to know that we're going to, if we bring a vendor in who's going to help us with it, or any health plan, not we, I mean, and I think anyone who hires someone to help them, they're going to want to know, what are the outcomes that I'm going to get from this, right? And so, and then I think some of the vendors are probably in a situation of, I've done this on a small scale, or I need my first client to sort of prove this out to you, right? And there is not an easy answer to say, oh, this is how we bridge that gap. But I think it's really around sort of increasing awareness and around innovation. So there are a lot of vendors in the healthcare space that are coming in to say, I do caregiving, I do heart failure, I do renal failure, right? So what Dr. Vemireddy is talking about is this full patient assessment, and thinking about what are other needs that health plans have that I can address when I'm in this member's home in front of them. So is it risk assessment? Is it making sure when she says gap, she's talking about other quality metrics around making sure members are getting appropriate care. And so I think that's going to be very important for vendors to think about, like, hey, I've taken the time to go into a patient's house, or I've taken the time to go in to call someone on the phone. I'm taking this comprehensive history. What's the value of all this information to a health plan, not just around the caregiving situation? And I think, number one, that's very important. I don't think anyone really has to be convinced that there's opportunity here. And so I also think it's about right time, right place again, about finding the people, finding the right vendor with the right team and a health plan that says, hey, I want to pilot in this spot. Like, I don't think saying, hey, we're going to turn over, 10 states of members to you, go have at it. It's not going to work anyway, right? Because there's different cultures and different issues in different populations. So thinking about a pilot. One thing I do think a vendor can bring to the situation that would help a health plan is, so we have supplemental benefits. Our biggest barrier is adoption, which that's surprising to hear, I think, right? But if you think about a hospital case manager, or you think about a primary care doctor, or a primary care provider, and the patient is sitting in front of them and they happen to have Highmark insurance and they happen to have the product that has the supplemental benefits in it and they happen to have the health conditions that meet the criteria for it. And it's the clinical situation that we've designed the package for. That's a pretty tall order for someone who's seeing multiple patients in a day. To sort of stop and say, hey, like maybe you don't have to go to nursing home, or let's not go to the ER. Let's put somebody in your house for a few days, right? That's a pretty big lift. And helping members to understand that they have the benefit, helping members and providers to understand, what is cool and innovative about this? Why does this help the member? Why are we saying, 2 weeks at home after a hospitalization is better than 2 weeks in a skilled facility for certain people? And that is an area where I think vendors can be very helpful when they come in to payers to sort of talk about, what are the economies of scale that I can get by being in front of your member? How can I drive adoption of this? And then also thinking about, I think everybody in healthcare is sort of walking this balance in this very vulnerable population about how can we scale and keep the care of the same quality. So where do wearables fit into this? Where does virtual fit into this? Where does agentive AI fit into this? Without making it impersonal to the member. And so I think a vendor that can speak to those issues rather than the value of caregiver support is going to go a lot further with a plan if they can address those things.
Wonderful. Thank you so much for providing those insights. And you've already started to touch on kind of the next set of questions about this implementation and scaling challenges and potential strategies to address them. So in the interest of time, and to make sure we hit all our points, I do want to shift and talk a little bit about measurement, which you also started to talk about. You're thinking about the measurement of outcomes, the ones that we expect to see the most movement on. And so I am wondering what each of you think the most, like, how should we be thinking about measuring impact in ways that are meaningful to families and to payers? Because we know that we have to be realistic about our business model, and just thinking about, yes, what you think are the most impactful measures to consider, and then any potential unintended consequences you think might arise from that. I'd be really curious about your thoughts.
I'm happy to kick that off and start. But, as I think about measurements, I mean, for, related to the MA member, we are looking at just overall, satisfaction with the plan, right? Are we helping to, what's their perception of the plan? Are they feeling that, they have a trusted resource that can help them navigate their needs, right, as it relates to their care? So we do look at closing SDOH gaps. We look at, quality measurement gaps, like whether it's screening or annual wellness visits or medication adherence or fall prevention, right? Because as part of our risk stratification is identifying who is at high risk for a fall and then putting in place the interventions to address that risk. So we line up the interventions with those STARS measurements. As well as, as I think about, and then, measuring, avoiding unnecessary emergency room visits and all of that, that may take, the claims data and, further analysis in conjunction with the plan to see sort of before and after the impact that we've had. But with respect to the caregiver, it's also looking at, their emotional wellness strain. It's looking at their burnout risk factors. What improvement have we made, right, so as we provided support to, their ability to take care of their loved one? Do they feel like their needs are being supported as well? And I do think there is that direct then tie-in with like CAHPS measurement, right? Because we know more and more like family caregivers are the ones that are filling in some of those CAP measures. So, a lot of times plans are thinking about, how we have to look at not just the support that that MA member is receiving, but the caregiver who is taking care of the day-to-day needs of that MA member. So those are some of the areas that we look at from a measurement standpoint.
Thank you.
And I'm happy to chime in as well. And I think Dr. Vemireddy talked about this a little bit earlier, in that before we can really measure impact, we've got to be able to assess the need for caregiver services and training to begin with. And, from what we've seen in terms of health risk assessments that health plans are required to do, Medicare Advantage plans are required to do, those assessments are really only hit or miss when it comes to assessing whether even Medicare beneficiaries have a caregiver who assists them. So, we've got to sort of know what we're dealing with first when it comes to that relationship before we can really look at impact. And I'll just mention really quickly, we are seeing some movement, even though, CAHPS and HEDIS and so forth, again, the measurement of how we're doing when it comes to addressing the needs of caregivers is somewhat limited. We are seeing some movement within CMS in that they adopted for hospitals, they're under their IQR reporting, what are called age-friendly hospital measures. And one of the domains that they are measuring has to do with what they call patient vulnerability, which includes caregiver stress. And that domain really seeks to ensure that hospitals, recognize the importance of screening older adults, particularly older adults who may have complex care needs, and have systems in place to be able to ensure that those issues are identified first and addressed as part of that person's care plan. So hospitals are now required to screen older adults for what they call geriatric specific vulnerabilities, which can include caregiver stress, isolation from the community, economic insecurity, limited access to healthcare, and as well as elder abuse. And those assessments are performed on admission and then again prior to discharge. They're also required to report on whether the older adult, the patient that they're serving, screens positive for any of those vulnerabilities, and then how they are in fact addressing them. So we're seeing some movement from CMS in terms of how hospitals are doing this. And hopefully we will also continue to see that and expand that to healthcare, to health plans as well. But I do want to mention, in terms of sort of the unintended consequences that you had asked about, Kate, is that, we really need to ensure, while we do need to address sort of the needs of caregivers, we also need to ensure that the voice of the beneficiary remains primary in all of this. And that by looking at, by sort of assessing and addressing the needs of caregivers, we're not bypassing beneficiaries or measuring quality only through caregivers.
Yeah, I mean, I'll add to that I think being at Highmark, I feel fortunate for that. I work in an area called the ECO, which is the Executive Clinical Office, and that we have a strong clinical voice in our executive leadership, and a very strong commitment from leadership around what is the health experience of the member. And so, I love the question, Kate, around, what are the unintentional consequences, right? So if you look at traditionally what we might be looking at in quality around readmissions or around avoidable ER use or things like that, that doesn't necessarily mean the member had a good experience or there was quality care given, right? So we do a lot of work around looking at our metrics, our KPIs, for any intervention or product that we might launch from the ECO. And we're very intentional about saying what are the operational, financial, and clinical metrics that we're going to look at, so that we have a balance of outcomes that try and meet all the stakeholders' needs, right? So, are we achieving the quadruple aim with this intervention, and try and pick KPIs that are either proxies, because sometimes you can't get directly at it, or ones that do directly measure that. I mean, one thing interesting where I work is in home and community care in the ECO, and we're thinking about days at home as something that is really important, because there aren't too many people who say they love to go to the hospital or to the doctor, and so, or the nursing home. So we try and look at that as well.
Excellent. Well, thank you all for providing those insights. And I know we have about 15 minutes left, and I know a lot of questions are getting answered in the chat, which is excellent to see. But I definitely want to make sure we leave a little bit of time at the end for additional questions. So as we start to close out this moderated discussion, I'd like to focus on looking ahead. And so I have two questions for you all. And I'd like each of you to kind of give your reactions to it. And if somebody, please feel free to just lift up what somebody else said if you just agree. But the first part of the question is, if I gave you a magic wand to fix one problem, what would it be and how would you fix it? And then the second part of the question is, I'm really curious what you all think is working well right now. What is giving you optimism for the future of caregiver supports in Medicare Advantage?
I'm happy to start things off. And just, certainly from our perspective, which is largely working with area agencies on aging and the social care system, I would say that, the value placed on social care within if I could change anything, it would be the value that's placed on social care within the current healthcare system. There's a tremendous imbalance in power between healthcare and social care. If you purely look at the expenditures by the federal government in terms of the Older Americans Act, which supports older adults and caregivers throughout the country, Older Americans Act, with the exception of during the COVID pandemic, funding for the Older Americans Act, even with the growth of the older population, and I would argue caregivers as well, for the recognition of the value of caregivers, has stayed largely flat, while expenditures for Medicare and Medicaid have grown exponentially, over the same period of time. We know that health happens at home. And community care or social care makes living at home possible for people with complex care needs and helps to help improve healthcare outcomes. According to the 2017 National Academy of Medicine report, only 10 to 20% of the contributors to health outcomes are attributable to medical or clinical care, and social or behavioral factors make up the other 80 to 90%. Caregiver support services are a really important part of that for people with Medicare and other populations that have complex care needs. But what gives me optimism in all of this is not only the numbers that I reported before in terms of the number of the contracting between healthcare providers and payers, and for CBOs and community care hubs when it comes to caregiver support services, but also that growth that I pointed out in terms of the number of plans offering caregiver supports as part of their supplemental benefits. In addition, on the Medicare fee-for-service side of things, we've also, with the 2024 physician fee schedule, saw Medicare add a code for caregiver training and services. So we're starting to see that pick up within the world of Medicare, and hope to continue to see that in the future.
Thank you so much.
I think my magic wand and my hope are aligned to each other. So, I mean, what gives me hope is the conversation and the changes that are coming as we switch reimbursement back, to value versus volume. So all of these contracting and value-based arrangements actually give me a lot of hope. But you do need a magic wand for some of it. And so it's really about time and training. So, we have a system that's sort of set up for probably people who need it the least in general, the way we move through provider networks. And so I think that where we could accelerate things is really in primary care, and having providers that physicians have patients have a real relationship with their provider, they have trust, and the provider has the knowledge and the time to convey that information to the patient. And I don't think that there really is a health plan, a vendor, a government organization that wouldn't get on board with that, because I think we know where we need to go. It's just helping the providers make that transition and having the resources and the readiness, and the financial runway to be able to flip how they give care.
And, just to add to that, I mean, I think what gives me hope and optimism is the fact that we're having these conversations, as Dr. Jaffe mentioned, right? There is more and more awareness to how do we support family caregivers, the importance of supporting family caregivers, the fact that they, are significantly growing and will grow over the next 5 years with the aging, population, and the fact that majority of them are also working. It's time that we have a more formal support structure for them versus, it really being ad hoc and family caregivers really left to kind of figure this out on their own. If I had a magic wand, I would say, as we are thinking about population health programs, whether programs that the care delivery system is putting in place, programs that the payers are putting in place, we need to go beyond just the pay out. Sorry, I think I froze a little bit, but we have to be thinking about not as we put in place population health programs, we have to go beyond just looking at the patient's needs. We have to think about who are the caregivers, of that individual, and really have this family-centered care approach as it pertains to population health. And because then I think we will broaden our lens to understand the needs of the caregiver and the care recipient. And so therefore that caregiver is not invisible, as we support that patient.
Wonderful.
There are a
Thank
couple
you so.
Yep. Oh, thank you. Kate, did you want to open up to questions okay, so the first, so there's a number of great questions as well as a number of comments. One of the questions that was raised is just, has anyone quantified the share of beneficiaries receiving caregiver services as a supplemental benefit? And I know, Marisa, you responded that you had not seen prior statistics, but I just wanted to open it up to the other panelists because that's such a core issue related to today's panel.
I'm not aware of any numbers that are out there nationally, and there are studies that are published individually from certain health plans and provider networks that are doing this, that can give you insight into what is successful. People aren't probably going to publish when they've tried a supplemental benefit and it hasn't driven adoption, and then because some of the health plans are for profit, ours is not, but some are for profit, they may view that information as competitively sensitive and not necessarily put it out there for public consumption.
Okay, so thank you. Another question that was raised, are the current reimbursements for these support services primarily fee-for-service, value-based, population-based, or hybrid models? If value-based elements are included, what quantitative measures are typically used to define value? This probably would go to Dr. Jaffe.
Yeah, so typically hybrid. right now. So they're usually layovers from usual care that a patient may be getting. So, you know, it's like I sit in a clinical arm of our health plan. Our members all have relationships with their providers. We have relationships with their providers, right? So we're not in the business of disrupting those relationships or bypassing them. We're in the business of trying to make it easier, enhancing what's happening. So it's typically a layover. It's something that if we're providing it, there are some provider networks that are doing this as part of a value relationship, and that they're receiving a capitated rate or a lump sum from a payer, and then they're choosing to use those finances to give a value based arrangement. There are not specific outcomes that there's not one specific outcome that would apply to every single person involved in this area or in this field. I'll go back to something that I said, that if you can't sort of quantify that you are, depending how your language, whether you're doing the triple aim or the quadruple aim, you need to show that there's benefit to the patient, that there is some financial efficiency, and that you can scale it operationally. And so if I was building a program like this or thinking about putting my toe in the water, I would make sure that you can address all three of those areas, because basically what we're talking about here is transforming healthcare. So when we're talking about getting, increasing the value, that is, there are multiple stakeholders in that equation. And so you need to make sure that you have an outcome for each one of those.
And if we have time, Kate, I'm happy to sort of chime in a little bit on this from the CBO perspective. And that is one of the things that we look at in our survey is what are the payment models that are presently being used when it comes to CBO contracts with healthcare entities. And I would say overwhelmingly, CBOs are still being paid on a fee-for-service basis. However, between our 2021 and 2023 surveys, we definitely saw a significant uptick in terms of the proportion of CBOs with contracts that were being paid either on a capitated basis, such as per member per month, or on a value-based that had value-based elements incorporated into that payment model, such as pay for performance and things along those lines. And the kinds of measures that were part of those contracts included things like timeliness output measures, such as the time to service start, a number of clients served, program or member engagement rates, reduced readmission rates for hospitals, improved engagement specifically with underserved or hard to reach populations, and the list sort of goes on. I'm happy to share some of this data with folks if they want to contact us at businessinstitute@usaging.org. It's also available on our website.
Great. Thank you so much. I want to note that we're just about at time. So I want to really thank our panelists for sharing their insights, their expertise, and their time today. I also want to thank all of you in the audience for joining and for so many thoughtful questions. Like I mentioned at the very beginning, we will share a link to the recording and related resources after the event. Please do stay tuned for future sessions about the business of health. And with that, we will officially close today's webinar, and I hope everybody has a wonderful day. Thank you.
Thank you.